We've heard a lot in this session about surgical and percutaneous interventions on the tricuspid valve, and the success of these procedures really relies quite heavily on very accurate echocardiographic evaluation of the tricuspid valve before and after these procedures. So in the next 15 minutes I'm hoping to outline a systematic approach for evaluation of the tricuspid valve. Before we can analyse any echocardiographic data, it's important to really understand the gross anatomy of the tricuspid valve and importantly the surrounding structures. It's only then that we can correlate the gross anatomy with pictures that we're seeing on two-dimensional, transthoracic and transesophageal and three-dimensional imaging. And then we're in a position to determine the mechanism of valve dysfunction and postulate an etiology for the problem and quantitate the severity of the dysfunction. Let's review the gross anatomy. This specimen shows the tricuspid valve from the surgical view, as the surgeon would see the tricuspid valve looking over the left shoulder of the patient. The tricuspid valve is the largest of the intracardiac valves and it sits almost vertically within the heart. It's a complex valve that contains three leaflets, but they're three asymmetric leaflets, with the anterior leaflet being the largest and semicircular in shape. The posterior leaflet is located posteriorly in the tricuspid valve position, and the septal leaflet abuts the septum. The posterior leaflet may be subdivided into a number of segments or scallops. When we come to look at our echocardiographic images, it's very helpful to understand the surrounding structures. The anteroseptal commissure of the tricuspid valve sits very close to the aortic root. The anterior leaflet abuts the infundibulum. The septal leaflet arises from the septum, and the posterior leaflet is adjacent to the diaphragmatic right ventricular free wall. This specimen looks at the tricuspid valve as if sitting in the right axilla. As I said, this is a complex structure that consists of a membranous fibrous annulus, three leaflets, a number of papillary muscles and chordae tendineae, and also right ventricular and right atrial myocardium. The tricuspid valve papillary muscles typically supply chordae to two adjacent leaflets. The anterior papillary muscle often supplies the septal and anterior leaflets, and the medial papillary muscle gives chords to the anterior and posterior leaflet. But in addition, there can be other chords arising directly from the septum, from the right ventricular myocardium, and also from the moderator band. The tricuspid annulus is a poorly defined fibrous structure that is not well defined, and echocardiographically can be best seen as the hinge point of the leaflets. The annulus is complex in shape, elliptoid and saddle-shaped. The annular plane is located lower than the mitral annulus, and in a normal patient is less than or equal to 8 millimetres per metre squared. The next step is to correlate the anatomy that we've just reviewed with echocardiographic imaging. Now, historically in the literature, there's been some disagreement about the precise nomenclature of the leaflets. This is why it's important to remember what are the surrounding structures when we're trying to decide which leaflets are which. I commend to you this well-known landmark paper by Luigi, who identified the three most important echocardiographic planes for examination of the tricuspid valve. The first view that the valve is seen in a standard transthoracic echocardiogram is the parasternal long axis view, when the probe is, the transducer is angled downwards towards the bed and the tricuspid valve comes into view. And in this particular view, the anterior leaflet is seen closest to the transducer anteriorly, and the posterior leaflet can be seen at the floor of the right atrium close to the inferior vena cava. In the parasternal short axis view, when the transducer is angled closer to the aortic valve, one can see the anterior leaflet closest to the transducer and the septal leaflet in close association with the septum. The parasternal short axis view at the papillary muscle level is really the only view where there may be an opportunity to see all three leaflets simultaneously, and this is usually only achieved when there is dilatation of the right ventricle. In this particular example, the septal leaflet can be seen closely associated with the septum. The posterior leaflet, that's seen at the diaphragmatic surface of the right ventricular free wall, and the anterior leaflet closest to the transducer. The apical four-chamber view typically shows the anterior leaflet associated with the free wall and the septal leaflet closest to the septum. The subcostal view is an analogous view to the apical four-chamber view, which again demonstrates nicely the septal leaflet associated with the septum and the best seen the anterior leaflet associated with the free wall. You can imagine, however, theoretically, angulation of the probe more posteriorly may bring that leaflet into view. In the subcostal short axis view, again, the anterior leaflet is seen closest to the transducer anteriorly and the septal leaflet in association with the aortic valve. The subvalvular apparatus is best seen from transesophageal imaging. In this particular example, where there is significant right ventricular dilatation in the 0-degree view, the subvalvular apparatus is nicely demonstrated. Transesophageal imaging is particularly useful in examination of the tricuspid valve for determination of specific etiologies of tricuspid valve dysfunction. Incremental information about the tricuspid valve can be obtained from transesophageal imaging, but its value is not quite as great as we see with the mitral valve. In this short axis view, transesophageal view, you can see the septal leaflet in close association with the aortic valve, and the posterior leaflet is seen at the floor of the right atrium, closely associated with the inferior vena cava. In this 0-degree view, again, analogous to the apical four-chamber view, the septal leaflet can be seen close to the septum and the anterior leaflet associated with the free wall anteriorly. The posterior leaflet is not clearly seen in many echocardiographic views, but in this example, the 90-degree transgastric view nicely shows the posterior leaflet located closest to the transducer, which in transesophageal imaging is located posterior to the heart. And the anterior leaflet again is associated with the anterior free wall of the right ventricle. It's useful to compare 3D imaging. This particular transthoracic data set can be obtained using real-time zoom or full volume loop data sets. This particular view has been reconstructed from the ventricular perspective as if looking up from the patient's feet. When looking from this view, the septum is on the right. So this helps identify the septal leaflet, as indicated by the S. The anterior leaflet is adjacent to the anterior free wall, and the posterior leaflet located at the diaphragmatic surface. The same volume set can be reconstructed from the atrial perspective or the surgeon's view, as if looking from the patient's left shoulder. In this perspective, the septum is on the left, readily identifying the septal leaflet in association, and the anterior leaflet is located anteriorly, and the posterior leaflet associated with the diaphragmatic surface. The next step in evaluation of the tricuspid valve is to determine the mechanism of dysfunction. The tricuspid valve dysfunction can also be classified according to a Carpentier's classification, as we're familiar with the mitral valve. The most common type of tricuspid valve dysfunction is functional or type 1, where the leaflets and chordae are normal, but for example the annulus is dilated or trauma has occurred to the leaflets. Annular dilatation, as we've heard, is common and can be a consequence of left and or right heart failure. As we've already been told, the septal annulus remains fixed and dilatation occurs along the length of the anterior and posterior annulus, creating a more spherical and less planar shape of tricuspid annulus, and in doing so, reducing coaptation of the leaflets, which can be nicely seen in these three-dimensional reconstructions. In some cases, the elongation of the anterior and posterior leaflets can give the valve a bicuspid appearance. Here are some nice images, three-dimensional images of annular dilatation of the tricuspid valve, demonstrating poor coaptation of the leaflets. And in some examples, you can see how a bicuspid appearance has developed. In this case, transesophageal imaging has been very helpful in determining the precise etiology of this tricuspid valve dysfunction. It's clear from the two-dimensional images on the left that there is significant tricuspid regurgitation in the context of a pacing leaflet, but it's not until we examine the three-dimensional image in detail that it's clear that the cause of the tricuspid regurgitation is impingement of the septal leaflet by the pacing lead. With frequent right heart instrumentation, there is opportunity for tricuspid valve dysfunction at the time of pacing lead insertion with trauma to the leaflet, impingement or adherence of the lead to the leaflets, or during right ventricular biopsy. This video shows a case of pacing lead adherence to the anterior tricuspid leaflet. And on the right you can see a 3D image of the anterior leaflet affected by the pacing lead. Involvement of the primary involvement of the tricuspid leaflets is a less common cause of tricuspid valve dysfunction. When leaflet motion is excessive, such as in the case of prolapse, or due to caudal elongation or rupture, tricuspid incompetence is common, and this is type 2 tricuspid valve dysfunction. But when leaflet motion is restricted, as in the case of fibrosis or scarring of the leaflets, type 3 dysfunction. And finally, the specific etiology of the tricuspid valve dysfunction needs to be detailed. In this short axis view, we see a case of tricuspid valve prolapse or type 2 dysfunction. Primary tricuspid valve prolapse is very rare, and when it does occur, it's usually in the context of mitral valve prolapse. The anterior and septal leaflets are most commonly affected, and in this particular example you can see prolapse of the anterior leaflet and some redundancy of the septal leaflet. We've heard about carcinoid tricuspid disease. This is where the leaflets are thickened and retracted and kept open, in this particular example, throughout systole and diastole. And the final approach is quantitating the severity of the tricuspid valve dysfunction. And this is a multi-modality exercise where we incorporate two-dimensional colour, Doppler, spectral Doppler information to, in combination, decide what the severity of the dysfunction is. And in most cases, the degree in which we use each modality will vary depending on the individual patient. Much can be gleaned from the two-dimensional images. It's important to examine the right ventricle, its size and its function, right atrial size and function, the movement of the interventricular septum, which can be often D-shaped in the case of ventricular pressure or volume overload. In this particular example, the right atrial septum is bulging to the left, indicating right-sided pressure overload. The assessment of right ventricular size is largely, but not entirely, qualitative in nature. In this example, it's clearly grossly enlarged, several times larger than the left ventricle, and it dominates the apex. Two-dimensional examination of the inferior vena cava is also important. On the left you can see pulsating movement of the inferior vena cava as reflected by the V waves, which we've heard about earlier today. On the right you can see that the inferior vena cava is dilated. Colour Doppler examination of tricuspid regurgitation is the mainstay of qualitative and quantitative assessment of this valve. The tricuspid jet area is a semi-quantitative way of determining the severity of tricuspid regurgitation. But as we know, there is some overlap in the grades using this methodology. More accurate assessment of the degree of tricuspid regurgitation can be obtained from using the vena contracta and PSA effective orifice area. The tricuspid vena contracta is measured as the narrowest width of the regurgitant jet at or just below the level of the valve, and a value of 0.7 centimetres indicates severe tricuspid regurgitation. There are limitations for using this particular technique, including we recommend that a Nyquist level of 50 to 60 be used, centimetres per second, and it's not as accurate for eccentric or wall impinging jets. With the PSA methodology, again, multiple or eccentric jets reduce the accuracy of this particular method. Spectral Doppler is useful in quantifying tricuspid regurgitation. On the left, the continuous wave Doppler examines the tricuspid regurgitant jet. In mild tricuspid regurgitation, this jet is parabolic and symmetric in shape, but with increased severity, the jet takes on earlier peaking triangular shape, and the density of the jet approaches the density of the inflow jet. Pulse wave Doppler of the hepatic and veins and inferior vena cava can also give clues to the severity of tricuspid regurgitation. With moderate tricuspid regurgitation, blunting of the systolic flow wave may occur, and in severe tricuspid regurgitation, systolic flow reversal is seen, analogous to pulmonary venous flow reversal in the case of mitral regurgitation. Put together these multiple, multimodality, qualitative, semi-quantitative and quantitative methodologies together can build up a picture of the severity of tricuspid valve dysfunction. A brief note on tricuspid stenosis. It's an uncommon condition and rare in isolation. When it does occur, it normally occurs in association with mitral stenosis. In this particular image, the tricuspid valve leaflets are thickened and restricted, and Doppler examination reveals elevated mean pressure gradients and a reduced tricuspid valve area as measured by the pressure half-time method and the continuity equation. Together with the two-dimensional findings of right atrial enlargement and inferior vena cava dilatation, a diagnosis of tricuspid stenosis can be determined. So in summary, the tricuspid valve is a complex structure. It's important to remember the gross anatomy of the valve and its surrounding structures, and to combine that with evidence from transthoracic, transesophageal, two-dimensional and three-dimensional imaging. Then consider the mechanisms of any present valve dysfunction and determine the pathology that is affecting the valve function.